So I'm vascular medicine at Mount Sinai. We split time in the vascular lab with the vascular surgeons, and I'm going to try to bring everything that you've heard together back to the clinical patient in front of you and how you can use ultrasound to help you guide your management. So these are my disclosures, none of which are relevant to today. I have three objectives. First, to set expectations for the treatment of acute venous disease. Second, to identify clinical and diagnostic variables that might influence your risk assessment and management of patients. And then use duplex ultrasound appropriately in the management of patients with DVT. So I think it's helpful to think about our treatment goals as a big picture. And really there's two, right? There's reducing the risk for pulmonary embolism and death. And then second, hopefully reducing the risk of post-thrombotic syndrome, which is not small. Up to 50% of patients will have post-thrombotic syndrome at 5 years of follow-up. And we can recognize that with the patient in front of us in the room with chronic venous changes. So I have a case to kind of guide the discussion. This is a 41-year-old male who presented with left calf pain. He has inflammatory bowel disease. He had recently flown from Greece back to New York. No history of venous thromboembolic disease or family history of venous thromboembolic disease. On exam, he's got left leg swelling. It was tender to palpation, and he had an elevated D-dimer. So he got a venous duplex in our lab, and what you can see is a non-compressible gastrocnemius vein that is dilated. It's got pretty echolucent looking material in it. I like to think about acute thrombus as almost like a sponge. It's very spongy when the probe goes on it and bouncy. And it's about 3.4 centimeters away from the popliteal confluence. So this distal DVT you've heard about this morning already. It accounts for up to 50% of all lower extremity DVTs, and up to a quarter will progress to the popliteal vein or cause a PE. And really, we're talking about these muscular veins and then the axial veins shown here. Now, the prevalence really varies based on the type of study that you do, whether that's a proximal only study up to the popliteal vein or a complete leg ultrasound, as well as the population that you're investigating. So if you're looking at patients who are presenting with suspected PE as compared to those with a diagnosed DVT, the prevalence rates are going to vary. In your labs, are you routinely doing complete leg ultrasounds? Yeah? Most of you? Anybody doing proximal only? Out of curiosity? I can tell you in our center it varies by the location. So some of the labs at Sinai will do proximal only. Our lab will do complete leg. But I think it's really important to know.
So in this presentation, we'll first review the protocols for duplex examination of the peripheral arteries. We'll go through the diagnostic criteria for arterial stenosis, occlusion, and aneurysm. And we'll discuss some of the strategies for correct interpretation. So what we'll do is, I'm going to start out with a couple of representative cases, really building on what Dr. Katie and Dodoff described as utilizing the physiologic tests. We always start out our evaluation of patients with presumed arterial occlusive disease, with physiologic testing. As she mentioned, if those exams are normal, there's really no need to go on and to perform a duplex examination. And if the exam is positive, then of course, then we can get a sense of not only that the patient has underlying arterial occlusive disease, but the area of interest. And that's where I think it's very valuable to include physiologic testing to get a sense of the location of disease. And then we can apply duplex imaging and focus on that area to really identify whether we're dealing with stenosis or occlusion in a particular segment. And that really helps to guide the therapy. All right, so my first case was a 65-year-old male with left leg claudication, history of smoking, diabetes, coronary artery disease, and status post-CABG. And you can see here, we're starting out with the physiologic tests. And you see that there's obvious discrepancy in our pulse volume recordings when we compare right to left. And if you look at the lower thigh level on the left side, we see there's a decrease in amplitude in the waveforms. And then indeed, if you look at the segmental pressure measurements on that side, you can see there's a decrease in pressure. So that gives us a sense of where we should be performing and focusing our exam on the left side. And here we're starting out at the level of the common femoral artery. And what I want you to appreciate here in this case is that we have a triphasic waveform, a rapid systolic upstroke. And this is really, I think, a theme when we talk about arterial studies. If you have a rapid systolic upstroke, if it's 90 degrees to the baseline at the onset of systole, in general, that means the inflow is normal, that there's not a proximal lesion. And we have that here. As we proceed inferiorly into the superficial femoral artery, you'll notice that we maintain that rapid upstroke. We're losing a little bit of amplitude in terms of velocity. We've gone from about 115 to 28 centimeters per second, which is a very significant drop. Yet we've maintained a normal waveform. What that tells me is there's probably no disease between those two levels. But then as I move even...
Hello again. So I'm going to give some case presentation of interest in peripheral arterial pathologies. Dr. Pilarito told me 20 minutes. I have 100 slides, so we'll go. 13. Okay, and counting. All right, some of the things maybe we already saw, so maybe I'll just kind of like fly through them. But so case number 1, 69-year-old female with significant atherosclerotic disease. And we're looking at the right side, left side, lower extremity, all throughout, and we see tarsus parvus waveforms. So one thing to keep in mind that this is an old patient, so probably not coarctation, and still could be aortic stenosis, but in this particular case, it was a very severe stenosis of the aorta, distal aorta. Okay, abdominal aortic stenosis with bilateral tarsus parvus waveforms. Next case, 76 years old, male with left upper extremity numbness. So we're looking at the subclavian artery, and we're looking at the medial and mid and lateral aspects with the color, without color Doppler, and we see that there is some, material within the lumen, and that was just a subclavian artery, partial thrombosis. This is a case of a 37-year-old male with hand numbness, and we're looking at this wrist ankle indices. We look at the right side brachial, pressures, and the left side, and they're symmetric. And then we're looking a little bit farther down, and it seems like everything is okay, right? So then we asking the patient to perform the maneuvers, is just like Dr. Needleman said. That's exaggerates the abnormality if there is one present. So this patient had near complete maybe occlusion or maybe stenosis of severe stenosis of the subclavians with the maneuvers. So there was a thoracic outlet syndrome with arterial compromise. And somewhat similar, presentation was in this patient who was 28-year-old male with also upper extremity numbness after exercise. We see that at 180 degrees of hyperabduction, we have a more or less normal velocities, 115 centimeter per second, and their waveforms are all fine. However, when we're looking at the left side with so this is at the baseline, and this is with 180 abduction. So we have very high velocities, like going up to, I believe it was 329 centimeter per second. And you can also see it on this chart how in the mid portion of the subclavian artery, it was a change, dramatic change.